Sorry, Dr. Mealy, I'll just transition. I'll just share my screen and transition
Perfect.
to the easiest.
Perfect. I will stop share at that point. Neither Snehal or I have anything to disclose. We have no financial arrangement with anything we're going to be talking about today. So today's topic is components of a successful practice, a team-based approach. So kind of going over the different components that best practice has recommended are helpful for operating office-based Suboxone. So we're going to talk about the importance of the team-based approach and kind of break that down, some of the jargon. I'm also going to go through some of the specific team members that would be recommended and some potential names or titles. Again, you can use whatever works for your organization. This is just some suggestions on how you could organize that team, the roles and responsibilities of each team member, and kind of how to think about how they fit together and how they can work flexibly. And then I'm going to shift over to Dr. Bott, and he's going to talk about some of the training components or the specific components for office-based treatment, and some of the supports that are needed by administration to really create that and assist in making sure that you have those structures in place for your clinical setting. So using a team-based approach, some note on treatment teams and why this is important. In the really sort of gold standard is what's called an integrated treatment team. So that's where you have multiple service providers, not just providing the different pieces of treatment for the patient. So you think about a multidisciplinary team is oftentimes kind of like a pie, and they each have a different slice of that pie, but they don't necessarily coordinate care together or meet to talk about and have a shared treatment plan. So really research has said for working with this patient population, we really need an integrated treatment team. So that means that they're integrated, they're meeting regularly, they're working together to address all of the needs of both the serious mental illness or comorbid mental illness and substance use. So we're treating all of it together. And that's the gold standard that's recommended by almost every regulatory or research body, that when you're working with an opiate use disorder population, this is really what we want to aim for. Why is this helpful? It's because it allows the clients to receive that combined treatment for whatever they're struggling with, right? So they're able to receive their medical care, their psychiatric care, their case management or care coordination needs, and their psychotherapy needs for any diagnosis that they have by that team, and that team meets regularly to coordinate what that treatment plan is going to look like and provide a consistent message about treatment and recovery goals. So they're not getting told different things by different providers, and everybody's kind of on the same page with what's needed to scaffold and support that patient. So again, there's that difference between multidisciplinary and interdisciplinary. We tend to use those words interchangeably, but that's not really in the literature what it means. So multidisciplinary means we all come from a different discipline and we're doing separate pieces of the pie, right? So as the therapist, I'm working on one treatment plan. Dr. Bott may be working on his own treatment plan, providing the psychiatric medication or the Suboxone. And then Dr. Jacobson might be working on another treatment plan where she's looking at the hepatitis C or whatever. That would be a multidisciplinary structure. So we're each doing a piece of the pie, but we're not necessarily working together, versus what's recommended is an interdisciplinary team. So we all come from different disciplines, but we bring those different perspectives to the table, and we meet regularly as a team to formulate the treatment plan and implement it together. So we have shared treatment goals. Even though we may be working on separate pieces, it's a shared plan. So that's really the gold standard, because we recognize that recovery is much, much more than sobriety or abstinence, that we're really looking at more than just how do we get those symptoms stabilized or those symptoms in remission. We have to also help this individual develop new meaning and purpose in their life to maintain recovery. So it has to be much more than just their diagnosis in remission. We really need to think about who is this person as a whole, and what are their goals as a whole to help them continue to choose that sort of healthy change, healthy healthy pursuits in life, in family, in work, in their community, that helps them remain in recovery for the long term. So in terms of thinking about our team, we want to think about who are the people that are working with that patient, as well as the patient themselves and any concerned significant others that are going to be involved in that kind of big picture recovery plan. We want to make sure that when we're working as a team and we're sharing that treatment plan, that we're also putting the ownership on the patient, that the patient has access to their treatment plan, that they develop it in collaboration with their treating providers, and that they are really invested in what those goals are, that they're not goals that we're coming up with, or goals that we're coming up with in collaboration with the patient. Because if they don't own it, they're not going to care about pushing it forward, right? It's just this another piece of paper that we're doing. It really needs to be something that the patient owns and feels is a good summary or synopsis of their overall recovery, their recovery plan, their recovery goals. So there needs to be an infrastructure in place within your setting to promote that kind of cohesion and allow the team to just focus on what needs to get done to benefit the patient. So there needs to be protected time for that team to meet and discuss these things, and to also meet with the patient and identify when we need to change those goals. And so one thing that's recommended for a cohesive team is to use the treatment plan as the fundamental document that underpins all clinical services and interventions. So every member of that team should be opening up that plan regularly, should know what's in that plan, and should be contributing to it on an ongoing basis, because that's the central hub where all of that clinical work is going to be recorded and collaborated on. So in terms of building the team, what are the components? So we need to have a structure. So who's on that team? So that includes the core team and the extended team. So again, we're thinking like big picture recovery goals. We want to have all of those people as part of that team, but you think about it as like there's an inner circle and then there's a larger outer circle. So that inner circle is your core team, and that includes the client or the patient, and maybe one concerned significant other that's very heavily involved in their treatment. And then the primary treating providers, so the people that actually have regularly recurring or more intensive intervention going on with that patient. That's the core team, and they're the ones that need to meet regularly and own the treatment plan. The extended team is also going to include other providers that work less frequently with that person. So it could be a primary care provider, it could be a dentist, it could be an external agency, or someone that you would need to get a release of information to include. So they're not necessarily going to be at those regular team meetings, but they may come occasionally, or we may coordinate care with them. And so we're still considering them part of the team. So what's the structure? So it needs to have some kind of a lead or manager that's really responsible for that treatment plan and the team as a whole. So making sure that we meet regularly and kind of coordinating those pieces, and that we're always documenting into the treatment plan when we do meet. So the team lead kind of takes responsibility for that. And then there needs to be and you can call this a coordinator, engagement specialist, recovery coach. So that's the person who's really responsible for the nuts and bolts of the documentation, the appointments, and making sure that all of the different pieces that are necessary to provide office-based treatment are happening, right? So that's kind of the person that really can drill down and knows all of those different components. Now, even though people wear different hats on a team, and I'm going to go through those different roles here in a minute, we still need to be flexible, because sometimes team members are going to be out, or there's going to be some sort of change that's part of that structure, and we need to be able to jump in and wear those different hats to support each other, to make sure that that those roles are still being fulfilled, and that structure is still maintained, even if kind of the players change or the hats that they're wearing changes. So now going through some of the specific roles, the team lead, or program manager. This can really be anyone that's independently licensed. So it can be kind of anyone from any discipline that wants to step into this role. But you think of them, they're the consistent, they don't necessarily have to be the person that has a treatment relationship with the patient, but they're a point of contact for that patient. So they're really coordinating all the communication across team members and making sure that that patient is getting that information. They may have some patient care functions. They may also conduct support groups or educational groups, or do other things as part of it. So a lot of the literature really supports that nurses are one of the best disciplines and are most frequently utilized to be in this role, that you can have a team lead, a nurse or nurse supervisor in this role that's actually a team lead for a large caseload of patients, 100 and 150 patients they may be in this role with. So they may not actually be doing clinical services with all of those patients, but they're kind of the responsible party for making sure that all of the components work. In terms of that role that really drills down into the nitty gritty and has a lot of contact with these patients, that role is either called a coordinator, recovery coach, or here at ASAP, we call them engagement specialists. And again, they can be from multiple different disciplines. They could be a nurse, a community health worker, a medical assistant, or even a peer support specialist. And it does require some training to be able to step into this role, but they're largely kind of doing a lot of administrative duties. So they're making sure that prior authorizations are done. They're checking the PMP, that whatever logs are tracking for this patient is happening. They may also be the person that when the patient shows to an appointment, they do a lot of the vital signs or collect UAs or do the clinical duties, and they provide a lot of patient education. So they may also meet with patients or do phone calls with patients where they're making sure that their appointments are happening, that if they need to come to walk-in or a scheduled time, that they're coordinating that. If referrals are needed, they make those necessary referrals. They're providing education on the basics of buprenorphine or harm reduction. They're sort of really kind of the person that makes sure that all of those miscellaneous components of treatment are provided for the patient. And so the patient gets to know their engagement specialist or their recovery coach really, really well, because they tend to have a lot of phone conversations with them and a lot of kind of side conversations when they come into the clinic. Now, making sure that we have that kind of extended team piece pulled together, anyone on the team needs to be able to do referrals. And so we recommend that everybody, regardless of your role on the team, that you have some kind of a list or you have a drawer with different pamphlets that you're able to make referrals to all of the different things that are going to round out somebody's care that you may not providing within your core team. So that could be 12-step programs, traditional healers, harm reduction sites, different HIV or infectious disease treatment sites or testing sites, people that are going to need things like resources to emergency food banks or housing, that sort of thing. We also recommend that there be somebody identified to provide psychotherapy for this patient. It is not required for people to be in office-based Suboxone, but oftentimes it's beneficial, especially when they're early in care, or they may have a comorbid mental health condition, PTSD, depression, anxiety, those types of things that psychotherapy would be recommended for. So this could be master's level or PhD level therapist. And these are people that have some specialty training in relapse prevention, MI, 12-step facilitation, other things that are really recommended for this population. And it could be somebody that's in-house and affiliated with your service, or somebody that's part of that extended team that you're coordinating care with. Pharmacist is also someone that we consider to be part of the team. And these are people that we want to have a good relationship with because they're going to help with naloxone distribution, providing education on the different medications. They're really kind of the first line to make sure that education goes out to other community representatives, first responders, physicians, and they can help with some of the pieces in terms of if chronic pain is something that needs to be worked on, and help the team understand, is this a high risk patient? Do they have multiple prescriptions? Are there things out there that we want to keep an eye on that they're catching on the pharmacy end? And then APNs or physician assistants. Obviously, they're vital team members and that they're going to be a possible primary prescriber, as well as administering naloxone. Same with the physician, but they may do some of the H&P or the more thorough assessment pieces, and then providing the buprenorphine prescriptions. They may also be someone that you pull in to provide training or education to the rest of the team as needed. Okay, so now I'm going to stop my screen and turn it over to Dr. Bhatt.
That's good. Thank you, Dr. Maile. You're just going to pull up my screen here. Okay. Let me find the right slide. There we go. I believe this is the slide that Dr. Maile, can people see it? Okay, great. So yeah, so in the next few minutes, I really just kind of wanted to just delve a little bit deeper into this, right? And I use the model of the kind of Massachusetts collaborative care model, not because it's the only model that's there, but I think it's a model that illustrates some of the points that we've been talking about. I think it does it well. So I'll go into those slides here in a minute, but this really is there, and I really included it as a reference to really highlight the fact that to provide optimal care to our patients, not just the prescriber, right? And not just the therapist or the counselor, but it really helps if the entire care team has received some training and education on various aspects of working with our clients, right? So I've kind of listed here, different things and who really ought to be trained. So for example, a lot of it should be all staff, right? Including, and maybe it's including the front desk staff. So basic understanding of addiction, of substance use disorder, right? How do you handle challenging behaviors and set appropriate boundaries? Again, all staff, because a lot of times, right, it starts right when the patient checks in, right? If the front desk staff or a person who's picking up the phone is treating the individual with respect and not using stigmatizing language, that can go really a long way towards setting a tone for the patient's care, right? And then there are some other things that I think, very specifically, if you use team-based model, certain groups tend to do, like follow-up visit protocol. So here I put nurse or medical assistant. And that's included because in a lot of these group-based approaches, team-based approaches to treatment with buprenorphine, the follow-up visits are generally handled by nursing staff, including the care manager that Dr. Maley talked about. Right. And PMP, the other kind of thing I want to draw attention to is the PMP, the prescription monitoring program, one selected agent for each site per prescriber. But in reality, at this point, at least in New Mexico, each prescriber can have up to 4 designees, right? So for example, I have 4 nurses and MAs within our clinic who can all pull the PMPs on my behalf. So when I go and see the patient, the PMP is already there in many cases, and I can simply review it, make sure it looks appropriate. And again, anything we can do to allow each person working within the team to the maximum of her or his licensure, the better we do. So that brings me to the Massachusetts collaborative care model. It's really one of the first and the most studied team-based models that we have, and a lot's been written about it. And again, other models out there, but I think this really captures what we're talking about. And really, Massachusetts was facing with something everyone around the country has faced, which is lack of providers who are prescribing buprenorphine and lack of access to care. So they really implemented this approach. Started with a hub and spokes type of approach that we all talk about, and of course we all do, right? Where there are hubs and various community-based spokes that work with the hub. And then they further looked at how can we really utilize non-prescriber members of a clinical team to improve access. And they found really amazing results. So through this approach, they actually increased waivered physicians 375% in the 3-year period, and wound up markedly increasing patients who were receiving medications for opioid use disorder. And that was especially the case with minorities. And here, nurse care managers that Dr. Maley talked about were central to the process. And they found that the process was actually financially viable and sustainable, and that a combination of 1 nurse care manager plus 1 medical assistant could reasonably treat up to 125 patients. So essentially a full patient load, right, for a waivered prescriber. And the idea really became, as that graphic to the right shows, bringing in services that might exist in-house, or if not, really partnering with other agencies that might be providing it in the community, depending upon the needs of the client, right? And that really sort of became the idea. And then this is kind of a nice workflow, which again, I think serves as a good model, right? So nurse care manager, you'll see, is doing a lot of the kind of day-to-day work, including the initial screening and the assessment, right? Then the review is, there's a chart review done during treatment team meetings to look at, does the patient meet criteria? What treatment plan might be the most appropriate for this patient, right? The MD, they use really MDs in that role. And I think this at this point can really be expanded to include nurse practitioners, physician assistants, right? To then do the physical examination, ensuring the patient has opioid use disorder, making the decision, prescribing, right? And then a lot of the follow-up visits are protocol driven, right? So nurse care manager has protocols for initiation instructions, follow-up visits, for talking to the patient on the phone if the patient tends to call in between, with the provider, the MD, serving really as a backup, allowing that person then to really ensure access to a larger number of people, right? And then this just a reference slide that looks at the initial screening assessment that was done in the model. And then I included a slide on the importance of training. What really the Massachusetts model, one of the things they focused on was that if we only have a limited amount of prescribers, right, and a limited amount of physicians, who are in a community or within a state who are sort of specializing in it, then one way they can really have the maximum impact is by focusing on training and building up capacity for other providers, other prescribers, as well as non-prescribing clinicians. So the physician, the leads of this project, really took on a major training role to build up capacity within communities, and then of course being available in a consultative capacity. And these are some of the things that was included in the training. And you guys got the slides, and you'll see that there is a lot of overlap actually amongst a lot of things that we talk about within our project here in New Mexico as well. Right? And all with the idea of building up local capacity, because that's going to be the best way to meet the demand, especially in light of rising rates of opioid use disorders, right? And then finally, I'm just going to glance at the time. It's almost time to end, but I'm just going to talk about the clinic administration. If there are any administrators there, your support is crucial. If you look at the literature on barriers to providers prescribing buprenorphine, it seems that administration, right, can really impact the process tremendously. If the administration is supportive, then you're going to see more prescribing happen and just better care. So support your clinical teams, allow for regular meetings, open communication, ensure appropriate staffing, coverage issues, and allow time for trainings and continuing education. That's a great way, not just to build up the expertise, but also to boost morale. And ensure that our providers, who are often, right, I mean, you guys know, you guys are all clinicians. We work in, at times very challenging environments, and it helps to feel supported as we do it, and seek input to that end of the team as we create clinic policies and guidelines. So in general, right, be an advocate, help create an accepting, patient-centered environment, work within the community and beyond to combat stigma, and work with your leadership to enact policies that ultimately benefit our communities, including funding, drug takebacks, education, youth engagement, of course, naloxone distribution. So I will stop here. And